And then we want to be lifting the shirt up to just below the breast and lowering the pant line to about the ASIS, okay? Why do we do that?
More real estate.
There's 4 quadrants, right? If the pant line is up to the belly button, you are missing 2 whole quadrants of the abdomen. Okay, you can't see them unless somebody here has X-ray vision. I don't, but we want to be able to visualize all 4 quadrants. Now, there's 2 different ways to divide up the abdomen. You do it in 4 quadrants, which is the vast majority of the time you'll be talking about right lower quadrant, right upper quadrant, left upper quadrant, left lower quadrant. But there's also a 9, there's a way to divide it up 9 ways. So you have the lateral 3 sections and then the medial 3 sections. And we'll go over that. And that's usually if you're getting more, that doesn't affect how you do your physical exam, but when you talk about your physical exam findings, it might matter. So like we talk about the area around the stomach, that section is called periumbilicus, okay? Or there's the hypogastrum, epigastrum, hypogastrum. And so we'll go over all of that. That's not gonna affect how you do a physical exam, it's just how you talk about things. So inspection, we're looking for any abnormal abdominal pulsations, we're looking for any masses, we're looking for any asymmetry, we're looking for any distension. Okay, if it looks like there's a balloon in their belly. And then we move on to auscultation. Okay, so I don't have my stethoscope, but this is what I want you to remember with the physical exam of the abdomen. Your starting point is always going to be right lower quadrant with everything that you do. And that's because the large intestine starts here. Okay, and we don't want to be fighting against the natural motion of the body. Large intestine starts here, contents move up, across, down, and out. We want to follow with that. We don't want to move against it, okay? So we'll start listening in the right lower quadrant. You don't have to listen for very long. You're just looking for those clicks and burbles that come along with borborygmus, okay? The movement, that peristalsis of the abdominal contents. So listening, if you hear movement, great. Listen to the other one, hear movement, great. Listen, great, listen, great. All 4 quadrants are accounted for. What you don't want to hear is nothing. You're just sitting there listening, and there's nothing. That's not good, okay? So auscultation comes before everything else. And again, that's so we don't affect those sounds with our palpation. And then we're gonna palpate those same areas. 2 hands, I usually come like this, and we're gonna do kind of a little circle, lightly first, then push deep, little circle. Then move to the next quadrant, light circle, deep circle. So what that looks like is here, and here's the tricky thing about abdominal exam. I'm not looking here, okay? That's not where I want to focus my attention. I'm looking at the patient, at their face. And that's because sometimes patients won't tell you something hurts, but their face will tell you something hurts. Okay? They'll grimace or something. They don't want to disturb you. They don't want to upset your physical exam. So sometimes they just won't say anything. But you're looking at their face, and their eyes are scrunched up, and you can tell it's painful. So as I'm only facing this way so you guys can see. But as I'm doing my light and then deep, I'm watching her to see if that hurt. And now I'm coming up, doing light and deep. Now I said all 4 quadrants, but I will almost always pay special attention to the epigastric area, that part where, midline, right underneath where the ribs come together, because there's 2 very important structures there, which are stomach. What else lives there?
Gallbladder?
Nope. Not diaphragm? I mean it is, but that's the dividing line between abdomen and
Liver?
Huh? Not liver?
Pancreas?
Pancreas, okay? Stomach and pancreas live midline. They live right here in the gastrum, okay? And then I'll come over here, and I'll come down to there. And then sometimes I'll even do the hypogastrum, so which is the suprapubic area. I'll push there too. Just make sure there's no bladder tenderness, okay? And then there's percussion. You haven't really learned this technique yet, but you use usually the middle finger of one hand, you put it on the skin, and then you're using the very tip of your other middle finger, and you're striking the fingernail, okay? So you hear that? So listen to the difference, see if you can tell the difference between this and this. Do you hear any difference? See if we can get
Less hollow.
less hollow. Which one was less hollow? Who said that?
Left lower.
So is it upper? Yeah. So when we're describing percussion, we're describing a sound like timpani. So if you think of a tympanic drum, you know, a timpani drum, it should be kind of that hollow resonating sound. That's if you're getting over an air pocket, you should hear a tympanic sound, or it could be dull. This is more dull. This one's a little bit more resonant. But then you can get people who are really distended where you hit it and it's like you're hitting a gong and you're just like, boom. Like you can hear the resonance, like you know that that's super hollow. But it's gonna be in between dull and tympanic, no matter where you're tapping, on a healthy individual, okay?
Does this how you check watermelon too?
What's that?
Does this how you check watermelon?
Yeah, kind of cantaloupe, yeah, same thing. Another technique is you can use your reflex hammer. Some people like that to strike. They feel like they can strike their finger a little bit harder and get a better sound. But I've gotten pretty good with tapping with my finger. This is why I also don't recommend anybody have like acrylic nails when you're practicing medicine, okay? Because it gets in the way and harbors germs and it's not great. So it will help you with your technique to not have nails.
Good.
So yeah, just remember inspection, auscultation, percussion, palpation, okay? Questions? Super easy. And what you're feeling obviously for any areas of tenderness, that's gonna be the biggest thing, but you're also feeling for like masses or asymmetry in the abdomen. There's a lot of variability between patients with the abdomen, just in normal, natural variability of where structures sit. But in general, you know, we've got liver and gallbladder up here, stomach and pancreas here, spleen here, and then the rest is guts. Kidneys, you know where we feel the kidneys? In the back, right? They're retroperitoneal. They don't sit inside the abdomen, they sit posterior to the abdomen. They're out of the abdomen completely. They're not even in there. So go ahead and sit on up. This is where we assess things like CVA tenderness or costovertebral angle tenderness. So we've got the spine vertically, posterior ribs laterally. They're gonna meet at an angle right here. This is the costovertebral angle, okay? So for reference, we're gonna feel for her ribs. We're gonna feel where they end and how they come up. Her kidneys sit right here, which is a lot higher than most people expect them. Everybody thinks their kidneys sit back here. No, your kidneys are actually up pretty high. So the way that we assess costovertebral angle tenderness, there's a couple of different ways. You can just do like a little heel strike. What I tend to do is I'll put the palm of my hand, the heel of my hand on that area, take my other fist and hit my fist, or my hand with my fist, okay? And you're just trying to send a little shock through their back to, you know, aggravate the kidney. If there's any inflammation of the kidney, like a kidney stone or
Nephritis.
yes. Why am I blanking on pyelonephritis? There we go. Pyelonephritis, then they'll light up. Okay. Yeah, then that's a very cursory abdominal exam.